A very good evening to you who is watching UBC TV. Thank you for joining me, Sophia Matovu, on U Health Chat, proudly sponsored by National Medical Stores. Now, the 25th of April is World Malaria Day. Actually, the whole month is used to be able to educate us about malaria. It is observed to spread awareness of the global effort to control and eradicate malaria. We are not the only countries suffering with malaria, but there is a bit of a problem now because government is trying to respond to the upsurge of malaria. And with me in studio to talk about that is none other than Dr. Jimmy Opigo, who is the Assistant Commissioner of National Malaria Control Program at the Ministry of Health. Doctor, very good evening to you.
Good evening, and good evening, our viewers.
Okay. Now, I'd like to ask you straight away, why are we experiencing a worrying surge in terms of the malaria cases? You know, I think it started a bit like towards the end of last year, and it seems to have gone a little bit higher this year.
Yeah, indeed, we made a lot of progress in bringing malaria under control. In the past 1 year and this year, we got a lot of reversals. We have worked hard to figure out what has gone wrong. Although it is what is not preoccupying us, what is really preoccupying us is how to get back on track, how to contain it. However, we think the possible things are the malaria parasite seems to have increased its power. That we call it in science virulence. It can do it by modifying its ability to cause severe forms of malaria. That is one. There are also indications that it has found a way to evade the medicines we are using. So treatment is not effective and transmission continues. We also have noted that mosquitoes, just like the ticks, have developed resistance to the chemicals we use in mosquito nets and for spraying, and even aerosols like Doom, Kill. But further to that, they have also had behavioral modifications, where instead of biting at the times we normally traditionally know, that is 10 p.m. to 5 a.m., they can bite as early as 6 p.m. before you go in your mosquito net, and as late as 9 o'clock at your breakfast table. They have also tended not to rest on the walls where we apply chemicals. They bite and go back out, or tend to bite from outside. That is on the parasite and mosquito side. On the side of humans, also a lot of things have happened. Because we have had successful prevention, we have a generation of young people who have not been exposed to malaria, and so they are non-immune. Okay. Again, we have abandoned, because of modernization, traditional malaria control efforts. You know, traditionally, when we build tukuls, the mud houses, we smeared it with cow dung on the floor and the walls. It was not only a house decoration strategy. In fact, the animals are so wise. When they are grazing, they selected eat particular things, including some which are medicinal and repellent to insects. That's why when we had a long time granaries, whenever you smear those granaries with the cow dung, no weevils get to your harvest. And our people knew how frequently to apply this. So this doesn't happen anymore. Traditionally, there were no TVs we watched in the living room. We sat at bonfires. Okay. The bonfires are not necessarily for funerals only, but we spend the evenings at bonfire, so the smoke and the heat kept away the mosquitoes. Now, for environmental reasons, modernization, and access to firewood now, this is out. Also, we banned dung, you know, cow dung. All this contributed. So this, our traditional methods of control also, we have abandoned them. Then there has been overall complacence because we made so much success that people abandoned the use of mosquito nets, care for them, and so malaria came back really with a vengeance. So our focus has been on how to reverse these issues.
Okay. I can see you started, the last time you were here, you did tell us that you were going to go into some of the interventions like the distribution of the mosquito nets. How far have you gone with the process, and what have you got to report so far?
So the government of Uganda has responded very firmly. First, at the cabinet level, this matter was discussed and it has received priority. It has received even priority where government business is coordinated in the office of the Prime Minister. It has received very high priority in the Parliament of Uganda through the Uganda Parliamentary Forum for Malaria. As you know, the Right Honourable Deputy Speaker of Uganda Parliament is a malaria champion. And so we have been supported to spray houses in West Nile, in Bukedi region, parts of Busoga, parts of Lango. We have had seasonal malaria chemo prevention treatment in Karamoja, now almost the whole of Karamoja. The government, working with its partners, has already secured 28 million mosquito nets. Over 7 million are in the country. We have delivered already in the epidemic regions. We have also secured additional funding for anti-malarials, and the areas which have a lot of malaria have received, their supply has been more than tripled. We are focused very seriously on blood collection and moving blood within regions, because in the area where we are facing malaria, there are a lot of severe forms with anemia.
Okay.
And so we are moving blood from different places. Also, government has decided to adopt the approach which was used for fighting COVID and even Ebola, what is called the incident management system, which involves whole of government approach and a very aggressive approach. So an incident commander has also been appointed for fighting malaria. And as we speak, we are down to about 11 districts in epidemic, down from over 70. So we are moving very steadily. In fact, next week, on the 25th, on World Malaria Day, in Bugiri, we are going to have the official launch of the distribution of mosquito nets. This time, not the usual standard mosquito nets. Because of the resistance which mosquitoes have developed to pyrethroids, we have got new generation nets, including what is now popularly known as Interceptor G2, will be launched in Uganda. Uganda will be the first East African country to deploy it. So we have people within the country since yesterday from the US, from Germany, the innovators. So we are going to be rolling this out.
Okay. Now, in the areas where you have started some of these interventions, would I be right to say they are the ones which have high cases of malaria or that are highly affected? Because there are certain times when we think the good things have to start from where we are.
Yes, so we are very guided. First of all, malaria control measures are needed all over the country. But there are certain things we need to prioritize and concentrate in particular particular areas. We are guided by a criteria, high level of cases, but also high severe forms, where children and mothers are most affected, and where there are more malaria deaths. So there's a criteria for prioritization, and where the health system is also a little bit weak. So we grade it and prioritize accordingly. But the whole country is of interest to us.
And for how long has the exercise been going, and what is the strategy and breakdown in terms of, like, you give yourself a time frame that by this period we should be done with the spraying? Is the spraying mandatory for all, or is it specifically in those areas that are highly affected, while everybody else will be entitled to a mosquito net? I beg to be guided.
Everybody in Uganda is entitled to a mosquito net. We use what we call a total market approach. There are several distribution vehicles. Even the Batembe with the mosquito net is a distribution vehicle. We should not wait for government to give us nets. But government every 3 years gives mosquito net for all people. But within the antenatal clinics and the maternities, because those bring new people, we give also there. Then through medical camps, things by Rotary, you know, when we have Taricita, the forces help us reach particular people, slum areas. And when we get pandemics, like we had to go to Mubende and Kasanda when we had Ebola. So that the fevers people get will not be malaria. We need to remove malaria, because everybody with fever, because most of these viral hemorrhagic fevers present like malaria. We need to make sure in such circumstances there's no malaria, so that we have few people to be isolated and investigated. Yeah. So there we intervene with mosquitoes, with mass drug administration. About timelines, the fight against malaria is a marathon. It's not a fast fix like Ebola, because it is an endemic disease. As I said here earlier, our vegetation, our temperatures, our being water said is a safe haven for mosquitoes. So what we do is to make, we cannot eliminate mosquitoes. Even where malaria has been eliminated, what is eliminated is parasites and cutting transmission. That's what we are trying to fight. Yeah. But the goal eventually is to be malaria free. The world's timeline is 2030. So we are supposed to be on a countdown. But it's not supposed to be just a supply side only. Every disease is defeated by actions of individuals and households. It's self-care, it's self-competence. And when we achieve that, we can move faster to defeating malaria.
Okay. Then what's the plan for the spraying? Because looking at the pictures and what you have been able to achieve, I've seen most of it, happening in those areas, and some of them are water houses. What is the criteria when it comes to some of the, is it also mandatory for all households, or it is done with the consent of a specific household?
So every household in Uganda actually requires to be protected against mosquitoes. Either screening the windows, we build houses with, with that screen so they don't come in, door shutters. We teach the house help to keep doors closed. We have the houses well lit. No mosquitoes are not there when they wait for darkness. However, at a public health level, we have zoned areas where there's most transmission and where people have no means to do any form of spraying on their house. We, in the elite population, even if we don't do residual indoor spraying, we can either afford repellents on our bodies, or we are burning a repellent candle, or coil, or aerosol like Doom, Kill. We are spraying. We are doing something.
Yes,
okay?
sure.
And that is highly encouraged. We should do it, as I said here before, on our own. The way no one helps us to fight cockroaches. No one helps us to fight rats and mice. I mean, no one helps us to. Yeah. So that same way we need to control house flies, for example. You know, it is household responsibility. Now, in some very highly burdened places, which are rural, it is government which comes and deploys it, and we need to achieve coverage. So we encourage everybody to open their houses to be sprayed, but we time it. Now, these chemicals can last on the wall 9 months to 1 year.
Wow.
Okay, so they can be sprayed once a year. We prefer to spray them in February, latest March, before the rainy season. The mosquitoes are very vulnerable by that time. They would have bred a long time ago. They are very old. You can knock them down. Before the rains come in March, no, when you have knocked down the survivors who have mosquitoes which have survived through the dry season. Okay, so we time it. So normally mosquitoes proliferate in March and April. Malaria is highest in May, June. Again, with the August-September rains, mosquitoes proliferate in October. Malaria is highest in November, December. They have a real knockdown in January, February, except southwestern Uganda, because it is below the equator. You know, they get their rain at a different time. Most Ugandans are not aware. When it is dry season on northern hemisphere, Christmas, January, in southwest there is rain. Yeah, so we time it, and we always get the information from the meteorological authority, and we time when best to hit these mosquitoes.
Wow, very interesting.
Yeah.
Now, among some of the things that you talked about when you're talking about the reason as to why we're having an upsurge, how about the fact that some of the people have gotten comfortable and they think that malaria has gone down? So you'll find that the net is like a decoration. Why put it down? Just dump it somewhere there in the box. The fact that you're giving people very good nets, why not use them for fishing or any other purposes? You've seen even others use them around their small home gardens. What plan
now,
do you have to
just
ensure
looking
that
right in the camera. Self-care is a lifelong endeavor. In fact, I thought Ugandans would even use masks for life, not only for COVID, but other respiratory tract infections, against pollution when we're in the city with all these fumes. Okay, Ugandans should continue hand washing for life, not only for COVID. Yeah? With all these diarrheal diseases, upper respiratory tract infections, which we get, viral infections we get by hand sex. Social distance, we should do it for life. You know, keeping you sexually safe is for life. Medical checks is for life. So it is not right for us to self-care ourselves for mosquitoes for some time, and when we have hit it down, we then go complacent. They come back. Mosquitoes are very adaptive, and they are one of the longest surviving organisms known. Now, because they have short life, they have 10 generations in a year. You can imagine every generation is more robust and is challenged by other things, and it adapts. And you can imagine how long it takes for us to come out with new technologies. By the time we target a problem, by the time the technology matures, the thing has changed. It has advanced.
True.
Yeah. So we need not to put down our guard. And it is not right for us to get these tools and use it for other things. I know there are a lot of priorities, but sometimes it's interesting. I know food is so important, okay, because its need is real. We also know money is very, very important. And we see most of the things given for public health, people prefer to use it for either generating food or generating incomes, like of course the fishing, the farming, which is misuse actually. There are right things to use for those purposes. Yeah.
Wow. At this particular time, I'd like us to take a very short break. And when we do come back, we're still going to continue into this topic of discussion, but I beg that you're part of it so you're able to pick a leaf.
Is it going well?
It is.
This isn't just a girl. She is the future. This is a teacher, a doctor, a community leader, our future president.
She is the future of Uganda. And as a policy maker, the policies I enact today will protect her from child marriage and teenage pregnancy. We each have a role to play in empowering our teenage girls to protect them from child marriage and teenage pregnancy. Because when we empower them, we empower our nation. Protect the girl, save the nation.
Take action. Report any case of defilement or child marriage to the police or call Sauti 116.
Jerry con. Jerry con. Hey, Master Blaster. Touch him, man. Bang Jerry con with muscle. Those ones who say go for you only. Mundava. Best movies I teach you. When I'm going to the musicali, because of the cover that is very far. Is you serious? Is serious you? What? Yeah? You step it on it. Add kilometers to your legs, and you get your sugar. We buy meat from Umaru, and Umaru refused to give you enough meat. Show him that they don't joke with you. Umaru,
Okukakaluka n'okulungi kwetaagako omuntu akuyambako. N'olwekyo tujja kukuteerawo embeera esaanidde osobole okukola ekisinga. Awamu teri kitulema.
Well, you're still watching You Health Chat, proudly sponsored by National Medical Stores, and we're talking about government's response to the upsurge of malaria. With me in studio is Dr. Jimmy Opigo, and of course, we'd like to say thank you to the Ministry of Health for always coming out each time we invite them to talk about things that are pertinent to us concerning matters of health. Now, Dr. Opigo, I believe we do have, of course, a malaria policy plan. What does it entail, and how is the layperson supposed to know what is entailed in that policy, and how useful is it to them?
Okay, so the focus in our policy is to ensure we empower all people to protect themselves. First, the awareness, the importance, and the prioritization of it, which we do by all the type of campaigns, communications, including this one, so that people prioritize this and take it as their responsibility. We also do everything possible to ensure tools are available for people to conduct this responsibility. So our focus is malaria prevention, prevention. There will actually, unfortunately, be few breakthrough infections. The policy is early and prompt testing and treatment. Because malaria is preventable, is treatable, and curable. And if detected early and treated within 24 hours, it's simple. It's simple. You may only be disrupted a bit, and even you can go back to work the next day as you take the medicine. After 3 days, it is done. The problem is if we don't do this after 2 or so days and it complicates to a severe form, it is very serious issue. You may need to be transfused. You may need to have IV treatment. You may need to get a drip. You may need actually respiratory support. It can harm your kidneys. It can harm your brain when you get cerebral malaria.
Oh, yes.
Yeah. It can kill. It becomes so expensive, especially among under 5 children, but recently even adolescents and teenagers, who especially have been well protected over the years and have remained non-immune. So we have seen even right now there are children on dialysis or high dependency support or ICUs because of severe malaria. It becomes so expensive just because we delay treatment, or we just give Panadol for the fevers, we don't test, or we don't finish the treatment. So it is really responsibility of people to prioritize this. But beyond this also, we are promoting now travel malaria, especially us in Kampala. If we travel up country, we go for festive seasons. We need to take care. The mosquito net can also be mobile. You can pack and go with it, especially where the houses up country may not be well fortified the way our houses could be in urban areas. And we adults also, if we travel on official duty in field work, we can get malaria back to the house. Because for us, we can contain it. We can be carrying the parasites and we contain it. We remain asymptomatic, but we are transmitting. We are also encouraging that in the homes, we don't only focus on our children. We protect the whole house, including the house helps. Because as we know, the reality is, for example, since we have not got back home yet, we are working. The children are under care of the house help.
Yeah.
Either move to their room, or the house help has moved into the bedroom of the children until when we get back.
True.
Is when they retire. So if themselves they are not protected, and we are giving nets or spraying only in the main house, they remain a reservoir for malaria transmission within the home. And that is why you will be treating every 2 months.
Oh, yeah.
Okay. The other thing we are promoting is malaria made some mistake. We have separated treatment from prevention. You see, the health workers know if you get a sexually transmitted infection, they want not only to treat you, but treat the source and the contacts.
Yeah.
They will tell you to bring your
partner.
partners. If they find you with HIV, they do positive prevention. They give you condoms, they tell you test your partner, they enroll you to care. Malaria, they will test you positive, prescribe you medicine, they will not talk to you about mosquito nets. Okay, you are going back to the home where the mosquito which gave you the malaria parasite is still alive.
Oh, yes.
Yes. And if you take medicines like Coartem, which protect you for 14 days, after 14 days, the same mosquito may infect you. Okay. So we are working with health workers to see how we put prevention and treatment together. In fact, there are over 20 million contacts of malaria between health workers and Ugandans in a year. So if all that opportunity is used not only for treatment, but promoting prevention. We have asked drug shops why they sell condoms and masks, but not mosquito nets. Because these are all barrier methods.
Yeah, true.
Okay, they are all barrier methods. See, instead, Batembe and the supermarkets are the ones selling
the
mosquito nets.
True.
Okay,
Very true.
so the health worker has not been in malaria prevention, has been in malaria treatment. Okay, so this is something we are trying to change. Even where we have put mosquito nets in antenatal clinics, all mothers who go for antenatal care will be tested for syphilis, for anemia. They will not be tested for malaria.
True.
Okay?
True.
See? Yet malaria harms a mother
And the
baby more than any other things. In some cases where we have put mosquito nets to be given to the mothers, the health worker would say, please attend all antenatal visits. When you finish, we shall reward you with a mosquito net. They don't see the connection that it is part of antenatal care. They are giving it at the end. Even in child health clinics, the focus is immunization. Immunization is very important. We should have it. But malaria is, I mean, the mosquito net is the shield for malaria, like the vaccine is for the other things. So it should be given on the first visit. So we are redesigning so that we put prevention moving together with the treatment. And we take advantage of everything, even the people, so that when we travel, we go to hotels, we demand that the hotel either has AC or has a mosquito net or has screens. Okay? We encourage people to demand, or they spray it, you know, at the time which hotel is called turn down. You know, you demand. And if it must be out, like in the camps. So we are working even with the Hotel Owners Association, with the tourism people, to make sure that everything is safe. So there is a whole switch towards prevention and leveraging all the advantages and the opportunities which exist.
Now, you've talked about all the strategies which sound very you know, beautiful, and certain times it is sad that we get to realize where we are actually defaulting when it comes to some of this. I'd like us to get onto the bit of the treatments. You did talk about Coartem, and there are certain times when somebody is given a prescription of those oral medication, they first look at the number of drugs and they're like, this is way too much. 4 in the morning, 4 in the evening, and you know, and then this the other day, and then the other day. So you find people tend to get comfortable and they'll not adhere to taking the full treatment.
It is interesting. There are many Ugandans, they are having non-communicable diseases or chronic diseases for which we take medicines for life.
Yes.
Like when you have pressure, you have diabetes, you have HIV, or TB is also for a very long time. And we learn to put it in our lifestyle to keep these medicines, some in the office, some in the car, some next to your bed, so that when the time comes, so there is some planning and some redesigning we make to be able to take these medicines for life. I think we have done a poor job as malaria people to talk just the importance of taking some medicine for 3 days. We have done a poor job. If those other programs of diabetes have made people to realize whether the injectable one you do in time, you take you align it to meals, you know, and people can comply. The fact that one of only 3 days, people take 1 or 2 days and leave, I think we have not properly communicated the implications. The implications are very serious. They include now the failure of the medicine we are observing, okay, and it affects all of us, okay. And when we don't complete with, after some time, the sickness comes back.
True.
And now comes back more difficult to manage, and we need to move you to another class of medicine for retreatment, which costs more. Yeah. So this is something we really need to deal with, and it ties to what I've always kept saying, that the supply side has to work together with the response or the demand side, because fighting any disease is individual responsibility. From taking care of yourself, making the medical checkups, complying with the treatment, including how the treatment is required to be taken. The Coartems, for example, need a fatty meal, which practically really means maybe a glass of milk, or where it is not there, some OD, you know, pasted, or either peanut butter or sim one. So some effort is required from the side of the affected person to achieve good absorption, because you have just taken it, it needs to be absorbed into your system to work. And then you need to also keep the time so that the levels are maintained.
Yeah, true. Now, my final one, little bit of that, I would like you to share with us the plan. Because, of course, as we've seen the beautiful, you know, work that has been done in some of the other areas, I guess everybody is curious as to when you're coming to their area, when you're coming to their region, when are they going to get the nets, when are they going to be able to get a little bit of the spraying in case the need is required?
Yes. So the mosquito nets, we have done a schedule. We have zoned the country in 6 zones, because it is logistically a very big operation.
Yeah, true.
Yeah? 20 million mosquito nets is very bulky. So we zone the country normally in 20 to 30 districts at a go. Is a massive operation. So we are starting with the countries having, districts having epidemics right now. We are intending to do it, distribute by next weekend. And then we move to mid-north, we move to Karamoja, we come towards the west, and then Buganda backwards, and central Uganda generally. We shall have reached all people by October. and this is there. But I need to use also this opportunity quickly, really, to talk about the remaining days of this World Malaria Month.
True.
So today, for example, we worked with private sector. You know, private sector has employees whom they want to keep safe from malaria, has families of the employees. If a child is sick, people don't come to work. They also have clients. If we look at, for example, plantation agriculture, they have thousands of workers. They even run clinics for them. Private sector can run clinics, sometimes buys insurance for its staff. Okay, so we have been working with them also. Why wait to treat when you can prevent? Also, private sector has a lot of platforms. For example, we have partnered with Safe Border. Can you imagine? Safe Border has over 25,000 riders who in the night are working. They are not in mosquito nets, and they are in the open and bitten them by mosquitoes, and they need to be protected. Do you know Safe Border alone transports over 600,000 people per day whom they can communicate to? 600,000 people, almost more than 500,000 people. You can imagine. Transport industry is so big. We engage also Jumia. Jumia right now is an alternative method for distribution of commodities. So at the comfort of your home, you can order a mosquito net, a repellent, sprays. Okay. It's moving. We are working with Uganda, but they have clinics for their people. We are working with different media organizations, including what we are doing, what we are doing right now. We are working with Uganda breweries. The other time, when we needed COVID vaccination, they pulled a trick. As like, for example, right now I may want to pass through the bar before going back home. And it was very easy to tell the men that if you are vaccinated, the bars will be reopened. And that even you can be vaccinated in the bar where we're watching football, we're watching your news and the others. And they had the power really to communicate, including on their various platforms. So beyond the traditional means of reaching, we are leveraging all private sector, you know. So today we activated with them. We are working with the Parliament. You know, today a lot on the floor of Parliament was discussed about malaria. Tomorrow they have a dialogue. On Sunday, the Right Honorable Deputy Speaker is inviting all of us for a parliamentary malaria walk. We shall walk from Parliament round and back, and then thereafter there are going to be some speeches. Parliament wants to provide some leadership in calling us all to action. You know, Rotarians have organized a bicycle ride. It's the third version. This time it's being taken to Mbarara because the Western Uganda, we had contained malaria there, but it is rearing back its ugly head. Partly because of failure of acaricides. The acaricides the people in the West applied on their animals was having a side benefit to us, killing the mosquitoes. So malaria is coming back. But also now the cow dung has found a new purpose. It's turned into fertilizer for the bananas. So the traditional burning of cow dung has gone down. Even the houses are now modern. They are painted. So malaria is coming back that side. So we want to draw attention back to it. So with Rotarians, we are going the other side. But the major commemoration is going to be in Bugiri, because Eastern Uganda, Busoga and Bukedi has been the epicenter of this response. So we are working, want to have a week-long action in that area so that we mobilize everybody into action. Yeah, because the supply side, government has done it. But government will not be there to pull down the mosquito net for you every day.
No.
Yeah. You know, will not be there to care for it, repair it. You know, it is individuals to use it well, not to wash it with jig because you destroy the chemical, not to dry it in the sun. You know, the ultraviolet light destroys the chemical. That's why we say dry it in shade.
Okay.
So most of the mosquito nets we give within a short time are ineffective because of wrong handling. So we are using all this opportunity to put this message out here so that the practice is a good practice.
Wow, that's a good one. Well, thank you so much, Dr. Opigo. We do really appreciate and can't take it for granted that each time we call on you, you're here to come down and educate the masses. Thank you so much for your time.
And thank you, everybody, for listening.
Okay. And for you who's been watching You Health Chat, I would like to remind you that on Friday, the 28th of April, in Boyogere, go to North Park Specialist Hospital for there is going to be a health camp that is there. The medical teams are out to be able to help us, and I'm impressed to see that at least most of the hospitals or clinics have come up to ensure that we can get free consultation and you're able to meet specialists in all fields. So 28th, North Park Specialist Hospital in Boyogere, and it's an open day where you can be able to meet any of the specialists at a zero cost from 9 a.m. to 5 p.m. That is all we had time for this evening. Keep watching UBC TV. Lauren Kazimoto Masika will be coming your way at 10 o'clock with the news. Good night.